Prabhu Shanker to come up to the podium. He'll be speaking on Rhegmatogenous retinal detachment complicated with proliferative vitreoretinopathy.
Thanks, Meena madam. Okay, once Rhegmatogenous RD is there along with PVR, so your surgery is always going to be complicated. Basically, two types of classifications are there. So the so it's grade A, grade B, C, and D. So usually once you see as C and D, so things are going to be more complicated and mostly will end up with extensive retinal surgery. So another one classification shows that where the fixed retinal folds are there, whether you're more dealing with posterior folds or folds anterior to the equator. So another type is there where it depends whether the folds are focal or diffuse or subretinal or circumferential or more anterior in the vitreous base. So I'll just show a couple of videos how we manage some of the cases. This is a patient with RD with CD with PVR. So we need once there's a significant CD all around 60 degrees, probably you have to take a decision whether you want to drain the choroidals and then proceed with the vitrectomy. So after the core vitrectomy is over, so just do a small sclerotomy around 8 millimeters from the limbus or where you see the CD was more dominant. And just with the MBR blade there, make a small slit and you can just drain off the fluid, a very simple procedure. And once you have, know that the CD settled down, then you can see a fixed retinal fold right in the inferior 6 o'clock position with a break there. So you need to gently remove off that membrane star fold there, then try to extend the vitreous base dissection beyond that star fold. So sometimes very difficult to go up to the aura. And so once the traction is completely released, and just check all the peripheral retinas, all 360-degree quadrants, and everything's fine, then you can go in for a fluid air exchange. So make sure that your cut rate is low and maximum cut rate of very minimal vacuum because you shouldn't catch up the retina there. So that's trimming that anterior this thing and just drain the fluid there. So I'm going for fluid air exchange. So it's all been assessed by PFCL. So our big advantage of PFCL is it prevents you, it helps you in dissecting the peripheral retina without much traction to the peripheral retina when they're jumping. So once your retina is well settled, you can just go ahead with the laser. The second case, you can see very bullous detachment with quite an extensive PVR in the inferior quadrant. So after putting PFCL, try to remove the break. So you can see the temporal break there, another large PVR fold, a lot of traction. So even this, we can put the PFCL up to the area where the break is there so that if you try, in case you put excess fuel, it might go under the break. So up to the break, fill the PFCL, I'm just draining the subretinal fluid. So you can see the retina going back. So now you can identify the break better. So just check the other quadrants. So once, just try to trim all those flap tires there. So here I couldn't remove the inferior PVR more anteriorly. So I just done inferior small area quadrant retinectomy. So make sure you cauterize. So once you cauterize, just whichever area the retina is totally fibrous, just extend the dissection. Always you have to do, whenever deciding to do a retinectomy, you will have to go into the normal retina. Make sure you remove all that fibrous retina. Once you feel the traction is relieved, then try to do the laser. So make sure you treat all the retinal breaks wherever it is. CD is still not fully settled, but it's in a bit that goes up post-operatively. So drain the fluid completely. So I don't do a direct PFCL oil exchange. Always I go in for air and then go. Complete of the laser. Make sure that retina is well attached. Make sure all the membranes are close to the anterior aura are removed completely. Once you do adequate laser at or 3 to 4 layers of laser barrage, then you can go in for the oil. The case 3, another case with a closed funnel RD. So here, in once close panorama, you're not able to visualize the optic disc. So you can see there is already crumpled up there, and you can see the macular pigments there. That's how you differentiate where the macula, yellow pigmentation is there, show the macula. So probably a membrane is right there, over the disc and the macula. Try to grasp that gently and remove that membrane. Once you remove that membrane, the funnel starts opening up, and try to trim the vitreous as far as possible. Once your vitreous dissection is quite adequate, then go in for a PFCL. So now you can see the funnel opening up. You can be able to visualize the disc and the macula. So keep trimming the vitreous as far as possible. Only thing is, you not create, already have retina, there are a lot of breaks there. Make sure you don't create new iatrogenic breaks. So keep injecting the PFCL slowly up to the edge of the breaks. Once you've done adequate vitreous brace trimming, you need to identify where all the breaks are there. Remove all the membranes around the breaks. So you can see that removing all the vitreous adhered. Trim the vitreous base. So you can keep injecting gently the PFCL if you feel want to settle. See, now I'm marking all the peripheral retinal breaks there. Identify the breaks with cautery. And then once you go in for the fluid air exchange, the retina well settled, then just laser the peripheral retina where all the breaks are there, preferably ideally to do a 360-degree barrage. This patient has been assisted by a belt buckle also. In case the extensive PVR is there, that you can always go with the belt buckle along with the vitrectomy. The last case. This patient also had an extensive retinal detachment, so a belt buckle has been placed and a large infusion cannula. Here the patient didn't have a PVD. So what we have done is, we have stained the posterior vitreous. So now gently we need to see where the posterior hyaloid is there. So with Tramslone assisted staining, you are able to delineate the posterior hyaloid from the retina. So gently lift it up. Once you clear the central core vitreous and the posterior hyaloid, then the retina opens up nicely. So slowly, gently trim the. Now inject PFCL. So you push all the retina subretinal fluid from the breaks. Then identify all the breaks. Do a very small trimming. This patient had a large tear, supranasal tear. So identify all the edges of the tear there, because sometimes under air you will not be able to see. So once you fill the PFCL up to the edge of the tear, you can complete the laser with the PFCL or go for a fluid air exchange, then do the laser, and then you can just go in for the oil. Thank you.
Thank you, Prabhu, for that very elegant presentation on one of the most difficult surgeries that we perform daily.